Diseases expert, Dr. Amish Adalja. He's a senior scholar at Johns Hopkins University Center for Health Security. Doctor, good to have you back on the program.
Thanks for having me.
Let's begin here because it sounds simple to say, okay, healthcare workers get this first, and in the next round, people with underlying conditions. But when I look at those, I mean, healthcare workers fall into a whole host of categories, right? I mean, you have people who are actually treating patients, but also doctors who don't necessarily see COVID patients, and then underlying conditions. Goodness, I mean, that's such a long and wide list, could encompass so many tens of millions of Americans. So how do you get a finer point on these categories?
So what will likely happen is that when a hospital, for example, gets allocated vaccine, they may say, we're going to give this to emergency medicine doctors, critical care physicians, hospitalists, infectious disease physicians, the ones that are dealing with the most COVID patients first, and the nurses that are working in those units, and then it may trickle out to other healthcare workers. It's going to be difficult, and I think it probably will vary from hospital to hospital, and maybe even state to state. This is sort of what happened during 2009, during the H1N1 pandemic. It was not very there was not a lot of clarity. I actually had to stand in line at a high school to go get my vaccine, even though I was taking care of H1N1 patients, and it came late. So it is going to be something that there's going to be hiccups, and it's going to probably have to be some fine gradation done. But it is going to be healthcare workers, and I think that's the right thing because we really are inundated with patients right now.
All right, so I worry when I look at that about the potential for favoritism, right? We've already seen that with some of these experimental treatments. I mean, things that the president got access to when he went to Walter Reed and other folks in the administration, not necessarily widely available to Americans who get sick from this. Are you concerned that, that folks who have some influence, maybe a little more money, move to the front of the line when vaccines are handed out?
That's definitely a concern, and I've already been called by reporters that have been asking me if sports athletes and Olympic athletes are going to be getting the vaccine first. So there's clearly that kind of jockeying going on. Hopefully that won't happen. Hopefully it will be transparent. You have to remember, this vaccine is a scarce resource. We're in the middle of a pandemic, and what we're trying to do with this vaccine is have the biggest impact on the trajectory of the vaccine, on the pandemic. So that means healthcare workers, high-risk individuals. That's what's crowding our hospitals right now, are people, for example, from nursing homes. So you want to end this pandemic, get back to normalcy, you have to use the vaccine strategically. And we have to use science and epidemiology to say, where is it going to have the biggest impact? It's not going to be vaccinating wealthy people or vaccinating professional athletes. It's going to be healthcare workers, nursing home patients, other high-risk individuals.
Yeah, you'll need some oversight to make sure that happens. Okay, let's talk about where we are now, because it's still going to be time before the vast majority of the country has access to this. Coming out, we are already in a bad place as a country. Going to Thanksgiving, a lot of people travel, family gatherings, etc. It's expected the numbers on the side of the screen are going to tick up. What do we know right now about what's really driving this expanded outbreak as we look at the graph there of the cases? Is it restaurants and bars, or is it gatherings that folks are having at home, social, family, with friends, otherwise?
So this is a bit controversial, and it has to do with the fact that we don't have complete capture of all the data through case investigations and case contact traces. You have to remember, though, that this is a big country and this outbreak is heterogeneous. Even though it's all red when you look on the screen that every place is going up, it's different. So, for example, in El Paso, it might be restaurants. But, for example, where I'm sitting in Pittsburgh, it really hasn't been restaurants. So you have to look at that data and then take targeted public health actions that are going to have an impact. And it becomes much harder when it is private gatherings in certain locations, because that's something that's very hard for public health to reach into or to actually have any input into, because you have to get people to actually heed those recommendations. Whereas if it's in a restaurant or a gym, you can put in mitigation, you can decrease capacity, you can have them change, you can look at them and see exactly what's going on. Are people not wearing masks, that kind of thing. But it's really going to be 50 different outbreaks and even multiple different types of outbreaks in a state. So that makes it much harder where we are epidemiologically.
Let's talk about schools, because you said you've been glad to see schools reopening here. And we've seen a sort of scattershot approach here. Some places close, some don't, some close and then reopen. We saw that in New York. What does the data show? I mean, have schools turned out to be big epicenters of this or no? And given that, what should schools be doing?
schools haven't been shown to be accelerators of spread. And if you look at the New York City experience, the number of positives related to the school system was very, very low. And I think that's why you saw Mayor de Blasio reverse the decision and start to reopen the schools, especially for younger children who are less likely to spread it. When you get into high school, they do behave a little bit more like adults, so you might get more transmission. But I do think that the priority needs to be having schools open. It needs to be the default. And we have to make schools safe. We have to do testing. We have to be measured about it. But I think that the data shows that this is something that can be done safely. And it really needs to be something where they're prioritizing school openings. In Pittsburgh, you can sit around a blackjack table, but you can't go to school. So I think that there is a little bit of difference in priorities. And I think this needs to be fixed. And the data actually supports this being able to be done safely. So I think that states should be moving forward with this.
Big impact on students and families. Dr. Amish Adalja, thanks so much.